Hi there. If you're watching this video, that means you're getting ready to have your knee replaced at Legacy Salmon Creek. My name is Wendy, and I'm part of the team that coordinates our joint replacement program here at Legacy Salmon Creek. And we have a bunch of information that we like to share with you before you even come in to make sure you have a good understanding of what to expect, and we don't want you worried or scared about any aspect of that. This is a video, so at any time you can pause it, stand up, walk around, take a breather, and we definitely want you to write down if you have any questions, and then just hit play again to continue the video. So usually this is a class that you're in person with us, and we don't want to lose any of that personal feel. So after you watch this video, at some point we will have a one-on-one conversation on the phone with you, so we'll be able to answer all those questions. So today we are going to cover the anatomy. We're going to talk about your knee and how it works and what it is that the doctor is going to do. So as we're talking about the procedure, we'll talk about the materials that he's going to use as well. This can be very exciting because they're lasting longer now. We'll talk about how to get your home ready so that you're prepared to have a good recovery environment at home. You're not in the hospital very long, so you want to have that all set up ahead of time. Then we'll also talk about what happens while you're here in the hospital so that you have a good idea, not be worried or scared about any of those aspects. And we'll review any complications that could happen, and we're going to teach you how to prevent it. Okay? We'll talk about how to manage your discomfort after surgery. That's kind of obvious that there's going to be some discomfort. Hopefully you understand that, but it can be managed, and that's a good thing. And then we'll talk about the therapy as well. Okay, and then again, if you have any questions, we want you to give us a call, and we'll talk about that on the phone call. Okay, so starting here with your knee, and if you were able to get a total joint replacement book already, you also have a picture of this in your book. Okay, so this is an x-ray of a healthy knee. So we're starting there so you can see what it's supposed to look like. On the knee joint, when you get an x-ray of the knee, all you can see is the bone. And the bones of the knee are the upper thigh bone or the femur, the lower shin bone or the tibia, and then this little guy right there, that is the kneecap or patella. Okay, so we can only see the bones here. This space, this beautiful space that you see there, is created because this person has cartilage. Cartilage is that nice thick pad in the knee that is the shock absorber for those two bones. There's a thin layer of cartilage also on the surface of the bone, which makes it look smooth on the x-ray, and it helps everything glide together slick and smooth and pain-free. This is a healthy knee. We look at that because we can see this beautiful space. We also look to see, is the space equal on both sides? Because as a knee starts to wear down, it tends to wear more on one side than the other. Okay, so that's what we're looking. When the doctor takes an x-ray of your knee in the doctor's office, they're looking to see, do you have any space? And then also this guy right here, that is the fibula. There are two bones in your lower leg, but that one stops right there, so we don't have to worry about him. He's not in the way. Okay, the knee is a hinge type joint. We like to type the joints in our body because it helps us understand them. A hinge goes all the way straight and it bends. That's all a knee does. Okay, this is a hinge type joint because of the collateral ligaments that are on each side of the knee. They make the knee stable. There should be no side-to-side motion in a knee. Okay, so it's a hinge joint, and it should have cartilage. Now this next slide gives you the picture of a bone-on-bone knee. Okay, so if you're having your knee replaced, what the doctor saw on your x-ray was that there probably was no space, at least on one side. And that's what is showing right here. So that is bone touching bone. There's no space because that cartilage is no longer there. Maybe it was an injury, maybe it was wear and tear just over the years, but that's what makes it where you need to have your knee replaced. So every step you take, bone is touching bone, actually can start to grind away the bone cells. Those can start to build bone spurs. Bone spurs then limit your motion. Maybe you can't get your knee all the way straight anymore. Maybe it doesn't bend as far as it used to. So that's not okay when it comes to a bone-on-bone knee. The other thing I like to point out on this is if this leg is supposed to be straight up and down with all that bone on the one side, can you see how this knee is starting to bow out? So that can typically happen as well. If the majority of your bone-on-bone is on the inside or the medial side of your knee, as that continues to wear, the knee tends to bow out. If it's more on the outside, it tends to knock in. Okay? And as that starts to change shape, because this is very common in people when their knees are wearing out, look at the pressure it's putting on that ligament that's supposed to be making your knee stable. This person's biggest complaint may not be pain anymore, like it is when it very first starts. His biggest complaint may be that it's unstable, that that knee could give out on him at any time, and that's not okay either. So with bone-on-bone, we have pain because we don't have the cushion, so you're suffering from that. Plus, as it continues to wear, it becomes unstable. Okay? And in this picture, you can also see kind of, it's not as clear, but the kneecap isn't in the middle anymore, and so it's probably bone-on-bone and painful under the kneecap as well. So that's what's happening, and this, folks, gets worse. This bone-on-bone, the more you walk on it, it gets worse. We do like to share that joint replacement surgery is elective surgery, which what that means is that it's not life-threatening. You don't have to get your knee replaced to save your life. What this is quality of life threatening. Okay, so yes, we definitely want you to get your knee replaced so that you can have good quality of life and be active again, but it's not life-threatening, so what's so good about that is we have time to plan. So we want to make sure you get all your ducks in a row before you have this surgery, okay? So it's not life-threatening, but it's elective, but we do want you to get it done because this will get worse. So as you're trying to decide, should I or shouldn't I, we want you to put that in the equation as well. This will get worse as you continue to try to walk on it, okay? Not life-threatening, but it will get worse. So those all need to come into your decision making. So if your knee looks like this, what you need is something that looks a little bit like this. This is a total knee replacement right here. And I would like to talk a little bit about what it is that the doctor is going to do in the operating room, okay? I have a model here that describes it as well. On my model here, it shows the upper leg bone and the lower leg bone. And when they do a complete total knee, it really is just the shiny part that is on the very end of the bone. It doesn't come all the way up here or all the way down here. If they did that, we would lose the connection of these very important ligaments on each side that makes your knee stable. So when they do that incision and they move your kneecap to the side, what the doctor is going to do is he's actually going to make those angled cuts that you see there. And each one of those angled cuts really is just removing a sliver of bone. But on that bone is the worn out part. So we can get rid of that. We don't want that anymore. So that removes the arthritis. And those angles are scientifically set up to match the inside of that prosthetic piece that's going to cap the end. So there's the new material that you get to walk on instead of that old worn out, rough, no cartilage surface. Isn't that exciting? This is a high polished cobalt chrome. Okay, now these materials used to say they would only last about 10 years, and that's back when this was titanium. Titanium's a great metal for the body. It just was too soft to be the bearing surface or the part that does all the work. So they updated that to the high polished cobalt chrome. Okay, on the lower bone, this is the piece that's going to cap the top of the tibia. Okay, so this cut here is going to remove any remnants of the broken up cartilage that are catching and popping now. It's also the cut that is going to make your leg nice and straight again. So if you were bowing out or knocking in, that one right there, the doctor is going to have that angle all lined up because he knows what the plumb line is and he knows how far out of plumb you are, and he's going to do that cut that will make your leg nice and straight. That is so obvious with people that come in with really bowed knees. They leave the hospital with this nice straight leg again, and that's exciting. Okay, so that's the piece that's going to top the top of the cap, the top of the tibia. In between those two metal pieces is your new cartilage, that white piece right there. So the metal pieces were updated from the titanium about the end of the 1990s. We went to a new plastic piece also about the 1990s, and they gave us about 20 years on that one. That's the one I got back in 2006. My replacement knee looks just like that in there, and I love my new knee. It's still going strong. So I've had it for 14 years now. But they've updated that plastic again, and that's exciting news for you guys as well. The new plastic is lasting even longer. They're saying about 30 years. The design of this new plastic piece, not only to be your cartilage, but also to give the knee stability. Okay, so that's in there as well. And the thickness of that plastic piece won't be determined until the doctor's in there working on it, because it kind of works like a shim. So the thickness will be determined based on how your soft tissue is around the knee. Okay, so just for example, if you told the doctor you wanted to be 2 inches taller, he couldn't give you a 2-inch piece in there because it'd be too tight. The knee wouldn't be able to bend. So his job is to be in there to give you just the right thickness to make that knee nice and stable side to side, but still be able to get a good functional bend and be able to get it all the way straight. Okay, and I like to explain this as well, because my bone spurs before surgery in my knee made my knee stop about here on the straightening. The doctor removed all those bone spurs, so now I have the potential to go all the way straight. But I'll tell you what, all this soft tissue back here, it had shortened, and it got used to being here. So the potential was there, but I had to do my therapy to reach the potential the doctor gave me. Does that make sense? That's why the therapy is so important. You got to do your therapy to be able to achieve what this new joint can do. Okay, as far as the bending, because we've got scar tissue here in the front with the incision, and the straightening. The potential's there, but we have to work at it. Okay, so that's pretty much the surgery. If you have any questions on any of those materials or how that works, we'll talk about that on our phone call that we get with you. Okay, on the x-ray, here after surgery, you can see the metal components. They show up really good on x-ray, and the plastic piece doesn't. Okay, so the plastic piece then is a beautiful space, just like that x-ray we had without arthritis, with that healthy knee. So we've got nice beautiful space again. And I'd like to show you this here too. Behind the kneecap as well is resurfaced. If that's bone on bone, that's painful. So the doctor can put what we call the patella button back there, and now we don't have bone on bone there either to relieve that pain. If you're bone on bone there, you would feel that climbing stairs. That kneecap works hard when you do that kind of stuff. So that will be better after surgery because of that piece being resurfaced. Okay? Okay, so that's pretty much the surgery. Now I'm going to start talking about the things that we need to do to get ready to come in to have surgery here at Legacy Salmon Creek. Okay? Some of the things that we expect with the services that we have. So the pre-admission services, or our PASS department, they're going to be ordering up some lab work. That's where you get that done. Suite 150 in our medical office building. They're also going to be doing some an EKG, and they'll be talking about your medications. The phone call from Patient Access is going to confirm your insurance and get all of your medications that you currently take into our electronic medical record, so it's there for the doctor after you have surgery to order. The nurse practitioners are going to be going over all of your medications that you're currently taking, including any blood thinners. So they want to make sure you're off anything that will thin your blood a good week before surgery. Okay, so anything that you're currently taking, they're going to give you specific instructions so you'll know exactly what you need to do as you come in for surgery. Okay, you should also have a pre-surgical appointment with your surgeon. So make sure you write down any questions that you have from the class, from any of the other appointments that you can go over with them. They're going to review your nurse practitioner findings in your medical history, and then they're going to have you probably sign some consent. If you're having a robotic procedure, whether it's a partial knee replacement or a total knee replacement, you also need to have a CAT scan taken about 2 weeks before surgery as well. Okay, so put that on your list. Okay, and then we have a checklist on page 4 of your total joint book that will help you be ready for that doctor's appointment to get all your thoughts in order and a list of questions. Okay? Okay, now you have to prepare yourself. Okay, so we want to make sure that you're going to heal well from this surgery, and that's why we include all of this information here. It's your cells that need to heal up after surgery, so they have to have good nutrients to do that, and that's why we want to make sure you're eating well-balanced meals. So your fruits and your veggies, protein, good carbohydrates, so that your body is nice and healthy. Now, if you get the pantry loaded up with all that good stuff before surgery, guess what? That'll be there for after surgery as well. We want you to continue eating well after surgery so you'll heal well. Drinking plenty of water is very important as well. You want to be well hydrated. Coming into surgery, you'll heal better. It's easier to start IVs on people that are well hydrated. You recover better from anesthesia. In fact, to the point where our hospital has you, it's okay to drink clear liquids all the way up until 2 hours before your arrival time. We want you to be well hydrated because you recover better. That hydration also helps you keep your bowels regular. There's nothing worse than being constipated because of surgery. And we know that narcotic pain medication constipates people. We know that anesthesia shuts your gut down. So we know that we need to pay attention to this. So please do not come to the hospital constipated, and make sure you have whatever works for you on hand for after surgery. In the nurse practitioner visit that you have before surgery, they'll even give you a shopping list of things that you can get that are good ideas to help with those bowels moving. We don't want you coming back to the hospital because of a backup there. Okay? We want you to limit drinking alcohol. We need you to take good care of your skin. If there's any scratches, abrasions, rashes on the area where they're going to make the incision, they could possibly cancel your surgery because we're fighting infection even from there. Okay, so we need good quality skin for that. We'd like you to quit smoking. That will make a difference in your healing as well. And to stay as active as you possibly can. As you recover from major surgery like this, if your heart and your lungs are working to their best, that's going to help you heal better. So we know we are limited with a bad joint, but this is going to help to remain active as much as possible. Okay? Also, we feel it is very important that you have a good team to take care of you after surgery. Again, it's elective surgery, so you have time to plan. Schedule your surgery around when your people, your friends, your family, maybe somebody from the church, whoever is available that can help you out. Because you're not in the hospital very long, and we want you to be well cared for when you leave us. Okay? So know that your support people, and it doesn't have to be just one person. We do want to train one person here in the hospital before you go home, but you can have multiple people help you take trips to your appointments and stuff as well. Okay? So these people are going to participate in your appointments, help with transportation. In caring for you at home, it is not heavy nursing care. They don't even have to change your bandage, but they're going to make sure you're getting up and moving when you should. Make sure if you're overdoing it to lay down and rest, to be putting ice packs on your incision, helping you with their medications and recording that on our paper that you record that on. Okay? So that's the kind of help that they're going to do for you. We say at minimum to have somebody with you for 24 hours after surgery, take you home, hear our teaching, take you home from the hospital, stay the night with you. If you live alone, at minimum that long. And the next day, if you're like, I'm doing great, you don't need to stay, but at least they'll check in on you. That's okay. If somebody lives with you, it'd be nice if they had a week off work. But we do ask that this person be at the hospital at 8 o'clock in the morning, the day after surgery, to get all the teaching that we're going to give you so you're confident in caring for the patient at home. Okay? Oh, now we got you packing before surgery. Okay? We do want you to bring your book to the hospital. Your book you should get at your pre-admissions appointment if you weren't able to come to class or the doctor's office. That has your exercises in there. Your therapist at the hospital will use those exercises. Pack any toiletries that you want to come to the hospital. Glasses, contacts, hearing aids, dentures. Those are, of course, very important. They're also small, and they can be expensive. So if you have a case that has your name on it, please bring that as well. If you use a CPAP machine, bring that. They're going to need it here. It must be clean and have all its parts in working order. We do want you to get dressed after surgery. as soon as you are able to. So something comfortable that you can get into, pajamas, light sweats, t-shirt, that kind of thing. And then you're going to need some sort of walking device, a walker or crutches. If you already have them at home, we're going to want you to bring that in. Your therapist needs to see what it is that you're going to use for walking before you get to the hospital. Please leave this stuff in the car, though, when you come to the hospital. Your coach or support person will bring it up to your room once it's assigned. Oh, and leave your jewelry and valuables at home. Okay. Now, as you're getting ready to come in the couple days before, you're going to get some special soap from your pre-admissions appointment and some instructions for your showering. There's a good 3 nights before surgery that you're going to be doing some showering with special instructions with clean sheets and clean towels. So go over those instructions. Make sure you got that set aside. The yellow to-do checklist, you get a copy of that when you pick up your book. On there, it gives you a good checklist of everything I'm talking about here in the class. It also gives you spots where you can write in at the bottom when you're called to know what time to show up to the hospital, what time your surgery is, and when to stop your food and drink. Okay? And about 2 days before surgery is when our patients get called to know what time to be here for surgery. When you come to Legacy Salmon Creek for surgery, where you check in is on the 2nd floor. Okay? For our campus here, the Skybridge for the parking structure, the 4th floor of the parking structure, the Skybridge comes across to the 2nd floor of the hospital. That is the floor you need to be in to check in. This is what the desk looks like. Behind that yellow wall there's a whole wing full of private rooms for our patients to be prepared for surgery. In those rooms, the nurses are going to have you change into a special gown. They're going to start an IV. They will clip any hair in the area where the incision is going to be. They will scrub that area again. Okay. You will get to meet your surgeon here. He comes down and he is going to actually sign the surgical site while you're awake, and you're both agreeing on where that is going to be. And then you get to meet with the anesthesiologist in the prep area as well. Okay, so if you have any history with anesthesia where you know you get nauseated, please let the anesthesiologist know. That way they can plan for that and treat you for that. Okay, so that all happens in the prep area. You can have one visitor back there. They're not huge rooms, but it's kind of nice to have an advocate. And then the waiting room is right here for while you're in surgery. There's also a full lobby here, and then the stairs up to the cafeteria is right there. The surgeon will need, or the people behind the desk will need your phone number of the support person. This doctor can call them after surgery. Okay. This is a picture of the operating room. We like to show our patients that because you are awake when you wheel into the operating room. This is where the anesthesia starts. So you'll see it's a big room. They got big lights and people in blue clothes, but most of them are all smiling. They're great people. So the anesthesia starts here. Typically our anesthesia will either be a general or a spinal. So that the anesthesiologist will talk to you about that. The surgery takes about 2 hours. Okay, and from the operating room, you'll do your waking up in the recovery room. All right, so the nurses in the recovery room then will watch you closely, keep you comfortable for about an hour, checking your vitals. You got to let them know if you have any pain at this point. Typically, with the way the doctors are doing more of a local anesthetic, we don't have a lot of pain in the recovery room, which is very nice. Kind of have a honeymoon phase. And they'll be checking to make sure that there's sensation, and if you have any nausea, you got to let them know because we want to treat any nausea before it gets any worse. Real quick, I want to go over any complication that can happen when you have major surgery. These are all things that have been issues in the past, and they're not showing to be issues as much anymore, I think mostly because we teach you guys how to prevent them, and that's really important. So we're going to educate you on this so you are empowered to not have any of these things happen. So these are all very preventable. You just need to know what to do. Okay, and the other thing that's really helped with this is that we get people up and walking right away after surgery. All right. So in preventing a bladder infection, we don't put a bladder catheter in and just leave it there anymore. If you get a bladder catheter, it's going to come out as soon as you can get up and walk, and that typically is the day of surgery. Okay, so we don't want a bladder infection. Those are removed the day of surgery. That's the plan. Also, constipation can be a problem with surgery because we know that narcotic pain medication kind of stops up your bowels. We also know that anesthesia can kind of make your tummy go to sleep, so it kind of shuts the gut down. And then we'll probably give you narcotic pain medication after surgery if you need it. So if we've got all that going on, we got to make sure you don't come to the hospital constipated. The nurse practitioner will talk to you about that and probably even give you a list of shopping items so that you'll have things on hand that'll work for you after surgery. But it's very important. You don't want to come back to the hospital because your tummy's backed up after surgery. That's not why you're having surgery. And getting up and walking really helps with that as well. Pneumonia used to be an issue, so somebody invented this handy dandy lung exerciser. This is a breathe in exercise, and when you're given this at the hospital, they will teach you how to use it. They want you to use it, I think, every hour. I want you to take it home as well and continue to use that at home until you're back to an activity level that you're used to. Okay, so that's the incentive spirometer, the lung exerciser. And then getting up and walking is very important as well. As you're up walking, I want you to take nice, slow, deep breaths. Okay? Preventing infection, of course, is everybody's concern. We don't want any infection. So like I was talking about before, we're starting with that in your home before surgery. You're going to start with your special showers with the special soap 3 days before surgery, including the morning of surgery. We're going to scrub it again when you're here in the hospital. You're going to make sure your skin's in good condition. This special gown in the prep area that they're going to use with you looks like this. The nice thing about the special gown that we use is that it's a warming gown. It's called the bear paw. They've got these little openings where a tube clips into there and it blows warm air into the gown, which is a beautiful satisfier for our patients because they love being warm, right? But the reason we do this is because the data has shown if we keep patients' body temperature where it should be, then it fights infection. So believe it or not, this wonderful warm gown is actually an infection fighter. So because we know that's the case, that needs to be working even when you're asleep. So you'll have the warming gown on and warm in the prep area, in the operating room, in the recovery room, and even back to your room, in your private room after surgery, it'll be on and warm. Now, if you choose you don't want to be in that anymore and you're in your own personal jammies, that tube can still be under your covers blowing warm air. So that's just some inside information. Okay, so that's all to prevent infection. Every one of our rooms has the alcohol dispensers so that people can be washing their hands as they come in and go out of your room. All of our patients get some IV antibiotics while they're in surgery. That is not because you have an infection. That is to prevent infection. Because you don't have an infection, you do not go home taking antibiotic pills. Okay? We've got wonderful bandages for our incisions now. They're sealed all the way around. In fact, you can even take a shower with those and you don't have to put anything else on there. So they're water resistant and you don't have to change them. They put the bandage on in the operating room. They want to keep that on unless it needs to be changed, which your nurse will instruct you if that's the case. But ideally until you go to the doctor's office to have your checkup. The last thing that they do, because this helps with fighting infection, is to make sure your blood sugar is where it should be. So they come in and check your blood sugars a couple times a day after surgery until you have regular blood sugars. If your blood sugar is a little elevated, that's kind of to be expected. That's what our body does after a stress of something like a surgery. So don't be alarmed if it is, but they may treat you for that. Doesn't mean you're a diabetic. Unless you are coming in. And if you are a diabetic coming in, you know that we've already been on top of that and monitoring your blood sugars. So blood sugar monitoring is very important to fight infection after anything like a total joint replacement. Okay? And then the last thing we really want to make sure you prevent is a blood clot. Now, the reason people would get blood clots after surgery is because they're laying around not doing anything. The heart's job is to pump the blood away. Our muscles are to get the blood back to the heart. So if you're laying around not doing anything, this is the farthest place from your heart and where a blood clot would be in the back of your calf. Okay? So it's very important to prevent that blood clot to be doing your ankle pumps, right? Be doing the foot waving. Can you see that? Okay. Our doctors also use special compression stockings. So you'll have a compression hose, and the point of these is to have nice support through this part of your body so the blood doesn't want to pool right here. Okay, helps with swelling. And then the last thing that we do are these lovely wraps. And these will start on you in the prep area. This wraps all the way around your leg. Hooks up to a motor that blows air, squeezes, fills up these chambers right here, and it squeezes your leg like a massage up and down. So these are kind of nice, feels good, feels like a massage, and it's actually your first line of defense against a blood clot after surgery. So these will be on and squeezing in the prep area and in the operating room and the recovery room, and they need to be on and working after surgery in your room. So if you got up and walked to the bathroom and you're back in the chair, if anybody forgot to push go on those, it's okay for you to say, you know, I learned at my class that those are supposed to be actually squeezing so that they're doing their job. Okay? All right, so now you've prevented every complication and you're going to do great. Okay, and now we're going to move on to managing your pain after surgery. We got to talk about this a little bit. Because it's very important to us. We want you to be comfortable as possible after surgery. And we really feel that communication is the main key, and that is why we developed this blue pain sheet, which is mentioned up there, okay? This blue pain sheet has on the back side the pain scale that is from 0 to 10, okay? So the 0 is, of course, no pain, and the 10 is the worst imaginable pain there is, okay? So we would like you to be able to rate your pain between there. 0 being no pain is probably not realistic directly after surgery, right? So we don't expect you to have no pain right away. We also don't expect it to be a 10, okay? And if we ask you what your pain is, you can't say it's a 12 because a 12 is not even on the scale, okay? So what we like about this scale is not only does it have the numbers that you can rate, because that can be difficult to do, but it has the faces as well as these descriptive terms over here that make it a little bit easier. So if somebody said their pain was a 7 to me, I might ask them, so is it miserable and distressing and you're unable to do most of your activities? I'm like, well, no, I can get up and walk. Then probably maybe it is more a 4. Now, a 4 is not no pain, and that's what we have to understand. That's still very uncomfortable, but it's not up here. And the reason we want to get an accurate number of what your pain is we want you to get just the right amount of pain medication. We don't want to over-medicate you, and we don't want to under-medicate you. And that's easier to do if we have more of an accurate understanding of what you are feeling. Okay, so that's why this is so important. On this blue pain scale sheet that we have on this side, you get to record when you take that pain medication. There's a spot for the date and the time, how much medication you took, what it was, and what your pain level was at that time. We want you to rate your pain so that you go back in 45 minutes. If that pain medication is working, that number should be going down, all right? These tools work great. They're a great communicator for your doctor as well after surgery. So when you go into your follow-up appointments, take your blue pain sheet so it shows when you have taken it. Hopefully you'll see that you're taking less and less pain medication as time goes on, okay? Because I'm going to share with you other ideas as well and other the reasons why this works so well. So it's so important to be able to communicate what your pain is so that we medicate you appropriately. We know that we're not going to expect no pain, and even with our more local anesthesia, a lot of times there's this honeymoon phase that we talk about, and you might not have a lot of pain that first day. But we do know it was a big surgery, and that is going to wear off, so you will have some discomfort even if you don't feel much that first day. So 0 is really not very realistic. We do want you to understand what's causing your pain. Okay, so that you're treating it appropriately. Are you hurting more because you sat in the chair all day with your leg down? Okay, so those kind of things. And are you taking any medication now for your pain? If somebody comes in for surgery and they have been taking a narcotic pain medication for a while and their body is used to it, they're going to be more tolerant to the narcotic after surgery. So this is a very important question, a conversation to have with your surgeon, so they are aware, what does it take to treat your pain now, so that we again medicate you appropriately after. So these are important questions. Most pain medication that is given to you as far as a narcotic is only given to you as needed. So after surgery, the nurse is not going to automatically come in every 4 hours bringing you a oxycodone or a narcotic pain medication. So you need to understand that. Don't have expectations that that's going to happen every 4 hours. So it says that as needed, which means that's the conversation and you guys communicating well. But if you do have some pain, if your nurse came in and asked you how your pain was and you said, you know, my pain is about a 2, I don't think I need a pain pill now. And as they left the room, your pain started to go up and now it's a 3 or 4, maybe working its way up to a 5. You don't wait for her to come back. You've got a nurse bell, call them, let them know, wow, it's hurting a little bit more than it did. It's trending up. I would like to stop that trending up. They can give you a pain pill so we can get it stopped at that point. Okay, so we don't want you to wait. Call your nurse if your pain is going up. We do have other pain management options, and if the pain pill that your doctor ordered for you is not working, if you recorded you took an oxycodone and 45 minutes later your pain is now from a 4 to a 5, oxycodone might not work for you. Your nurse can help you order another pain medication to give that a try before you leave. So know there are other options. If you know oxycodone doesn't work for you, make sure you have a conversation with your surgeon about that so they order something else. So we can try other pain medications if that one's not working for you. Our goal is really to figure out what works for you before you go home. Okay? Different ways to manage your pain besides the medication would be changing position, getting up and moving, ice, elevation, and rest. These are things I'm going to talk more during the physical therapy section. But the medications that we use is a combination of medications that seems to be extremely successful. We've figured out that Tylenol around the clock really does help. It's a base level pain medication, but it is an over-the-counter without the side effects of the loopiness and the constipation. So Tylenol is a great medication to take. The Celebrex was added. That's twice a day, and that's an anti-inflammatory, a prescripted anti-inflammatory, which helps with the discomfort as well. Many of our patients can get by with just using these and not needing much, if any, of the narcotics. So I just want to be very encouraging with you on that. Make sure you try this combination. And then if you need a narcotic, great, you can take that. It will be ordered. You will go home with a prescription of some narcotic pain medication so that you can treat it as needed at home. But we really want to encourage our patients to understand our patients don't need as much as we used to take back even 10 years ago. So if you've had a surgery in the past, we don't want you to come in anxious and worried about this part of it. This is really helpful, along with the more local anesthesia. Using the narcotics just as needed, if needed, is working great. People need minimal amounts compared to what they used to. Okay? It is very important if you take a narcotic, though, to take it with food, because it can be real hard on the stomach. We're already working with that with the constipation. We don't need you nauseated as well. So please, please, please always take that with food. Whether you're in the hospital, make sure your nurse gives you a snack with your food, with your pill, and when you're at home as well. Have some snacks handy. Good protein snacks works best, not just a cracker. I know when I had my surgery, I needed at least a full piece of toast with a pain pill. So that I wouldn't get nauseated. Okay, now I'm going to go more on the physical therapy side of things when it comes to pain control. I bet you thought that physical therapy was supposed to hurt, but I'm telling you right now, when it comes to knees, knees like to move. So you do major surgery on a joint that's made to move and you don't move it, it gets really achy and throbby. Okay, so I just want to go over that with you, making sure you understand what's causing your pain. So it's going to be important that you get up and move, and and do your exercises and not just sit in one place. If you sit with your leg down, that's going to make it really achy. And on walking as well, sometimes we feel like we can do more than we should and we've gone a little bit too far and we need to get home and get our leg elevated. This is going to actually treat the cause of your pain versus staying with my leg down and just taking a pain pill. That won't get as much relief as this will, and I'm not going to get loopy off of this either. So when we talk about elevating your leg, we literally mean we want that knee and that foot above your heart. We want the foot higher than the knee, and we want them both higher than your heart. So this is a great setup as far as getting that leg elevated. So as you're planning ahead here, we want to make sure you got plenty of pillows ready and ice packs in the freezer. In your total joint book on page 6, there is a recipe. You can make homemade slush packs with rubbing alcohol and water. It's a real cheap way to have some good Ziploc bags, double bag them, get them in the freezer. You can go to a medical supply place and get gel packs. That works great as well. We don't care what you use for ice. Just know you're going to want to make that knee nice and cold in that elevated position at least 5 times a day. Okay, so if you want to get those fancy wraparound cold water circulators, that's wonderful as well. There's usually a cost to that. I have my phone number at the end of the class. If you want to call me and talk about that, that's great. But we do need you to be prepared with ice for your knee. Elevation, the pillows, extra pillows, and then exercise. Before I go into the exercises, I want to show you this machine here as well. This is called a CPM. That stands for Continuous Passive Movement. Our doctors here order this, and we have them here at the hospital to use while you're here. Okay? If you lay down in your bed with your leg up in this cradle, it's elevated. You push go, it starts to gently move within the parameters you've told it to, and that gentle movement makes it not stove up and ache. So this really helps with the discomfort. You put an ice pack on it as well. You've got elevation, gentle motion, and ice that are all decreasing your discomfort. You're going to need less narcotic pain medication. So that's why we use these. This is optional. You do not have to get a CPM machine. You have one here in the hospital. There's no charge to that. You can have one at home as well. When we talk on the phone, we'll give you the phone number for the fellow with Medcom. They will deliver a machine to your house, set it up, show you how to use it, bill your insurance. Typically it's covered, not always. That's why you're going to need to have a conversation with him. And then you can have one of these for about 2 weeks at home is plenty. And this really helps with your discomfort and doesn't have bad side effects. That is not your therapy though. That is not going to make you stronger. It's not going to make you more coordinated. That happens when your brain and your muscles work together. So this is going to take me then to your exercise program. In your book on page 24 is where exercises for knee replacement begin. I need you to open up to those pages. I want you to look at these exercises. We've got pictures. We've got explanations. This is what is going to be expected out of you after surgery. This is very important. Your doctor's done. He's done all that good work. Now for it to be successful, you have to do your work. Okay, so I want you to read through it, and I want you to practice any that you can between now and surgery. This is your prehab. Okay, so that's very important. We've got prehab, and then we have your rehab after surgery. There's a couple pages worth. You need to understand it's not easy. You have to do your work, but it is well worth it, because if you do your therapy, you're going to have great range of motion, and you're going to have good strength in that leg. We expect all of our knee replacement patients to bend their knee to a good 90-degree angle before you leave the hospital. The incision is right there, and it's just fine. You're not going to hurt that. Anywhere you have an incision, you can have scar tissue. Scar tissue is strong fibers, and they're knitting you together. That's not bad, but if you don't move it, they're going to stick to everything else and you won't be able to move it. That's the hard part about a knee. If you don't bend it, it's not going to bend. We have about 6 weeks before that scar tissue turns to cement. So it's going to be very important for you to gently but diligently bend it and straighten it. You can go slow as you want to as long as it's moving. As you're gently moving that knee, you're going to take any scar tissue that's trying to bind down and you're going to tell it to be organized and orderly so that in the end you get a good bend in that new knee. That's my new knee, and that's how far it bends, and I'm really happy with that, okay? And it goes all the way straight. We got to get it straight, and we got to get it bent, okay? Then you're going to love your new knee, but the therapy really matters. These exercises are your home program. The majority of your rehab is what you do at home. So get ready for that. Think about that as you're preparing your house. Where am I going to do my exercises? Where should I put this machine? Probably on your bed so you can use this when you're resting. You got to elevate and ice 5 times a day. You could do these on the bed, on the other side of the bed, on a couch, a good firm couch. Just look through them and figure that out for you at home. And then on top of that, you'll go into the clinic for some outpatient physical therapy at least twice a week. And that's where you meet with a professional, and that professional is going to up that program. These are going to be way too easy in about 2 weeks. So they're going to get you on the stationary bike and up and down stairs, one right after the other, and leg press machine and high-level balance activities. So you need to figure out, why are you getting this done? What are your goals? What do you want to be able to do with this new knee? And you got to think outside the box sometimes if you haven't been doing much because your knee's been bad. Your potential's huge. You're going to be able to do a lot. And that therapist in the clinic is the person that's going to help you make those goals. Okay, so talk to them about it. Make sure they're working you towards those goals. You want to get in and out of your fishing boat, but it's moving and your knee's moving. You get a good strong knee, you're going to work on that balance, and that's not going to be a problem. But you got to work at it to get there. Okay, so hopefully I've inspired you a little bit with that. It takes work, but you can do it. You're going to get there. So those are your home exercises and your prehab. Therapy here in the hospital is going to work on your home exercise program. We want to work with your coach from home as well. So it's very important that they're here at the assigned time to be able to go over those exercises with the therapist after surgery as well. They're going to work on getting in and out of bed so that you can do that. Usually nobody needs any help with that. And then to be able to walk well. And it's important to walk well. Patients use a walker like you see here, a front-wheeled walker, the 2 wheels in the front. You can use crutches, but on the day of surgery, everybody starts with a walker. It's most stable. It stands up by itself, and you can kind of lean on it. Now, to do this correctly, you got to stand up straight and tall and just have a little bit of bend in your elbow. Okay, so you got a little push off. So you have good posture, standing up straight and tall. The way you walk is just 1 foot in front of the other. Can you follow me? Okay, just 1 foot in front of the other. We don't need you to do the wedding march, all right? And we don't want you to limp. But when you go to put your weight on that new hip, this kind of tightens up and bites you a little bit. You're not doing anything wrong, but it may make you limp. The walker's job is to take the limp away. So instead of limping, put a little bit of weight on your arms, take the weight off of your sore leg, and take that smooth step with the other side. So the job of the walker is to take your limp away. Okay, so you can go walk nice and smooth. You can walk as far as you want as long as you're not hurting too bad and you're not limping. Okay, so you may walk 100 feet the day of surgery. You may walk 400 feet the day of surgery. You don't have to lean on the walker. You can just push it along, but you don't get to limp. Does that make sense? You don't have to lean on it, but you don't get to limp. Okay, and that will change as the anesthesia starts to wake up. If it hurts a little bit more, you're going to change. You put a little more weight on the walker. Okay, so your coaches, your support people at home need to understand that at home you don't get to limp either. We don't want you to get rid of the walker until you can stand up straight and tall and walk without it, without a limp. So if they're limping around the house, you know what happens when we keep walking with a limp? You're going to throw your back out and give yourself a bursitis in your other side. So don't walk with a limp. Use the tools that are there for you so that you can do good quality therapy. Okay, so we're going to be working with you with your walking in and out of bed and your exercises. And if you have any stairs, we want to practice those before you go home as well. Okay, so with the stairs, it's just up one at a time, up with the good, up with the good. The one that didn't have surgery can do all the work. You can go upstairs. On the way down, you go down with the sore leg, down with the sore leg, and then you can go downstairs as well because the good leg's going to do all the work. We do want you to have a good sturdy hand railing to hang on to for that. Okay, so stairs are not a problem. The only time that's a problem is if you don't have a good leg, which you have to assess. How's that other side? Can it do the work? So practice at home. So after you get done watching this video, you're going to get up and you're going to go pick up all of your loose throw rugs and your bath mats. Anything that is a tripping hazard, please get it out of the way. Falling is never an option for any of our surgical patients. So that's not going to be an option. You do need to get some walking in too when you're home after surgery. So you're going to be doing some laps in the house. So make sure you have clear pathways. So pick up boxes and get stuff out of the way before you even come in. So your throw rugs are out of the way. You're going to pick up litter. You're going to get pathways clear. If you have stairs, they're fine as long as you have that good sturdy hand railing. So if it's wiggly, get somebody to screw it down tight. Raised toilet seat. This is usually the lowest seat in the house. So if you'll go and assess your toilet, when you sit down on it, is your knee higher than your hip? Then it's too low. You need to get one of those raised seats, and if you get one with the armrests on it, that works really well. Again, it's mostly so you're independent and don't get stuck there. That is not a good place to get stuck on the toilet, right? So we need one of those, and then you'll need a walker or crutches. Typically, our patients use a walker after this surgery, but we can talk about it on the phone if you're thinking you want to use crutches. This is not a lifestyle change. This is a recovery. So because you're only going to need it for a couple weeks, anywhere between 2 weeks and 6 weeks, depending on the patient, you can borrow one from a friend. Get grandma's out of the barn, go over there to Goodwill and pick one up. That is totally fine. But if you have one of those, we need to see it. We need to know that it fits you and that it's in good condition and you know how to drive it. So your coach or support person is going to keep it in the car until your room is assigned after surgery and then bring it up so the therapist can assess it and make sure it fits. If you don't have one, we do have brand new walkers here at the hospital that can be billed to your insurance. So if you want to do one of those, we can do that, and then it will be delivered before you leave the hospital, and our therapist, again, will adjust it for you. Okay, so we need to know that you have safe equipment for doing your walk-in when you go home. All right, so on the day of surgery, you're going to come from the recovery room up to your private room after surgery. On the day of surgery, we're just waiting for that leg to wake up enough so that you can get up and walk. We do expect everybody to walk the day of surgery. If your walker's not here yet, we'll use one of ours, not a problem. Once you have that successful walk, then the nurses will take out any bladder catheter. And once you prove to the nurse that your bladder works without that catheter, then they can unhook your IV fluid. Now you don't have any tubes. You can get your own clothes on. So get your own comfy jammies on. You're covered up for the next walk in the hallway. Okay, so that's all the day of surgery. We need you eating and drinking and good pain relief too. So you should have ice packs on that incision anytime. We've got the nice gel packs while you're here in the hospital. Just ask your nurse for another one if that one warms up. Then the day after surgery, that's the day we expect everybody to go home. This is the day we really need to have your coach or support person to be here about 8 o'clock in the morning. We have a lot to do, but typically people only need one physical therapy session with their support person before they go home. So this little folder is going to be at your bedside, and it's got the check boxes. See, this is the most popular question we've had to answer after surgery. So we put it on the folder. These boxes all need to be checked before you can go home. So your surgeon's going to come in and round, and then he's going to check your box because he knows there's no orthopedic reason to spend another night in the hospital. Then the medical team, the nurse practitioners that said you were healthy enough to have surgery, they come in and check on you. If there's any reason for you to stay any longer in the hospital, it would be for medical reasons. So they're going to be in charge of that part. Okay? The RN coordinators, part of my team, they're going to be rounding on you, seeing where you want to have your prescriptions filled. They do some teaching with you as well, and then they'll check their box. So typically you'll do your therapy session, your coach will run over and pick up your prescriptions. You can fill them right here at our outpatient pharmacy. And then you come back from across the Sky Bridge, and the nurse will do the discharge instructions, and then you can go home. Okay, so this is a busy morning. And then inside this folder is where we keep your blue pain medication record. Okay, so this is right at your bedside. Anytime you get a pain pill while you're in the hospital, either the patient or their support person needs to write it down on this. This is for your records. The nurse is putting it in the computer. This is for the patient. Okay. There's our team. And that's the end. Hope you enjoyed that information, and do expect a phone call from our team, either myself or one of our nurses, because we want to answer all your questions. And if you have any other concerns, please let us know. Thank you.